Well, thank you very much again for joining the session this afternoon, or this morning rather. And it is a real pleasure and an honor to be able to participate as a speaker in this session for aimed at primary care practitioners. And really, this next 15-minute talk is going to focus on what we consider a new standard of care in heart failure with reduced ejection fraction, with some key takeaways focusing on a primary care audience. These are my disclosures. And really, over the next few minutes, a couple of short objectives. One is to review the updated evidence for patients with heart failure and reduced ejection fraction, or HFrEF, and to highlight the new clinical guidelines from the Canadian Cardiovascular Society on the management of HFrEF patients, to discuss the importance of optimizing medical therapy for these patients, and to discuss key tips for medication titration in heart failure with reduced ejection fraction. So if we go all the way back to the big clinical guidelines update in 2017, the Canadian Cardiovascular Society guidelines really focused on getting patients with low ejection fraction and heart failure on triple therapy. That is to say, patients with an ejection fraction less than 40% with symptoms of heart failure. The goal, or the name of the game, was really to get them on an ACE inhibitor, a beta blocker, and a mineralocorticoid antagonist, and then reassess symptoms and determine whether or not these patients were candidates for what were then novel therapies, substituting their ACE inhibitor for an ARNI, or angiotensin receptor neprilysin inhibitor, or adding ivabradine, a sinus node slowing agent, for patients who had sinus rhythm and elevated heart rates. However, over the last 3 or 4 years in particular, there's been new data, new clinical trials that have informed our guideline process and the way we make clinical decisions. This is a busy table, but I'll just highlight some of the key features that have driven an updated guidelines indication. So for example, there was a study called the Pioneer HF study, which was really a study, a randomized controlled trial looking at sacubitril valsartan, or ARNI, compared to an ACE inhibitor, enalapril, in patients who were admitted to hospital with heart failure and reduced ejection fraction. This was a short trial looking at only 8 weeks of follow-up and looking at differences in natriuretic peptides between the two groups. And the implications of this trial was that maybe we need to broaden our use of the ARNI class of medications in patients who are hospitalized with heart failure, and even among those who have a new diagnosis of heart failure. And if you look at the second and third lines of this table, there were the nearly twin trials of the DAPA-HF study and the EMPEROR-Reduce study, looking at SGLT2 inhibitor medications, dapagliflozin and empagliflozin respectively, in patients with chronic ambulatory heart failure, low ejection fraction, and looking at the outcome of worsening heart failure or cardiovascular death. And the implications of these studies, which were nearly identical in their outcome, is that we should think about adding SGLT2 inhibitors in the broad spectrum of patients with heart failure and low ejection fraction, irrespective of whether or not they had diabetes. And then finally, there was something called the Victoria trial, which looked at a novel compound, vericiguat, a new class of medication that's known as the soluble guanylate cyclase stimulators, compared to placebo in high-risk, vulnerable heart failure patients. And the idea is that maybe this new compound, this vericiguat, can stabilize high-risk patients and avoid future hospitalizations. So with opportunities, or more tools in the toolkit, so to speak, we have some challenges. If we go back to the original treatment algorithm or treatment pathway, where should we now put ARNIs and SGLT2 inhibitors in a treatment algorithm? Where do we put new compounds like vericiguat, or soluble guanylate cyclase stimulator? And what is the role of vasodilator therapy and digoxin that are more historic or conventional therapies? And when should we refer for device therapies like defibrillators and resynchronization pacemakers? So I mentioned the Pioneer study at the outset, and this is looking at the primary study and the open label extension phase that follow patients beyond the 8-week initial trial period to up to 12 weeks. And what happens is that at the end of the trial, when everybody gets switched over to sacubitril valsartan, our ARNI, what we can see is that there's a further decrement in natriuretic peptide measurements, and particularly in those patients who initially started out on an ACE inhibitor and were switched over to the sacubitril valsartan, there's a much more dramatic decline in natriuretic peptides, which just means the drug is working as we would expect it to work. But the real action is on the right-sided graphic. And what you can see here is that compared to the ACE inhibitor enalapril, those patients who were started in hospital on sacubitril valsartan actually had an advantage with respect to heart failure, hospitalization, and mortality. In other words, there were more clinical events if we delayed initiation of the sacubitril valsartan until after the patient was hospitalized. And so how do we interpret that and put that into an updated guideline? Well, the top bullet is the conventional recommendation from a few years ago, and that is that an ARNI, sacubitril valsartan, should be used in place of an ACE inhibitor or ARB in patients with heart failure, who are symptomatic despite otherwise good medical therapy. And that was a strong recommendation that hasn't changed. And that was based on a trial called the Paradigm heart failure study from several years ago now. But what's new is that we now recommend that patients admitted to hospital with acute worsening heart failure should probably be switched to the ARNI from their ACE inhibitor once they're stable. And that's a strong recommendation, again, with moderate quality of evidence. And then finally, based on subgroup analysis from that trial, it would be reasonable to start patients with new onset heart failure on an ARNI as opposed to an ACE inhibitor right out of the gates. And that's a weak recommendation because, again, subgroup analysis informing our thinking. If we switch gears a little bit and go back to the SGLT2 inhibitor studies, I mentioned DAPA, HF, and EMPEROR-reduced trials. And if you compare the trials, there were slight differences in the patient populations and the way they were treated with background therapies, but that's really sort of small details and minutia. In the big picture, these were similar target populations with low ejection fraction heart failure, looking at the similar outcome in patients treated with an SGLT2 inhibitor versus placebo, whether or not they had diabetes. And you can see the nearly identical hazard ratio or benefit of the medication compared to placebo with respect to the primary outcome of CV death, cardiovascular death, and heart failure hospitalization. So this is pretty compelling stuff. And in fact, there are meta-analyses subsequently that show an unequivocal survival advantage to SGLT2 inhibitors over placebo in this patient population. So on the strength of that, we now recommend that an SGLT2 inhibitor such as dapagliflozin or empagliflozin should be used as standard of care in patients with heart failure and reduced ejection fraction, whether or not they have diabetes, to improve outcomes in heart failure, quality of life, heart failure hospitalization, and the risk of cardiovascular death. And then just to frame the last bullet, I did want to point out that there is an extremely vulnerable phase and period in the heart failure patient journey, and that is the period following hospitalization. So if patients get admitted to hospital and subsequently admitted, we can see that their risk of dying goes up dramatically, such that by the time you've had 2 or 3 or 4 admissions to hospital, we start to measure life expectancy in the order of months, sometimes weeks, rather than years. And in particular, that highly vulnerable phase is when patients are first discharged from hospital within the first month, but certainly within the first 3 to 6 months, they're at a much higher risk of dying than they are as they make it longer following discharge from hospital. So we've identified a subgroup of patients at very high risk. And the idea is that if we can intervene at this period, then maybe we can change the trajectory of the outcome. And that was the idea behind the Victoria trial, which looked at vericiguat, which is a soluble guanylate cyclase stimulator, relatively new in the heart failure landscape. And this really functions pharmacologically to increase the sensitivity to endogenous nitric oxide. And this looked at patients with chronic heart failure who were recently discharged from hospital or who are recently required intravenous diuretics. There were 5,000 plus patients in this study, and it was vericiguat compared to placebo, looking at the outcome of cardiovascular death or heart failure hospitalization. And if you look at the bottom line for this trial, the top line here is that there was a modest but significant reduction in the primary outcome driven by a reduction in heart failure hospitalizations. This was a hazard ratio of 0.9, suggesting over time, over the 1-year follow-up, a 10% risk in risk reduction with respect to heart failure hospitalization primarily. So the recommendation that flows from that in the new guidelines is that vericiguat should be considered an additional optimal heart failure therapies in HFrEF patients with worsening symptoms and a recent hospitalization. That's a conditional recommendation, rather, based on moderate quality evidence. Conditional because it's not yet approved by Health Canada, although that could change shortly. And so when we've got these new guidelines, how do we put this into a decision making? How do we prescribe this practically? And the approach we've taken as a guidelines group is to really think about clinical factors and getting patients on foundational therapies. So the top line here, and we'll explode each line of this treatment algorithm, but the top line is that we want to get patients on either an ACE inhibitor or an ARNI, plus a beta blocker, plus a mineralocorticoid antagonist, plus an SGLT2 inhibitor as quickly as possible, and then reassess for clinical factors that might drive an indication for additional therapies. If they have elevated heart rate, for example, consider ivabradine. If they've had a recent hospitalization, maybe there's a role now for this vericiguat treatment. If they've got atrial fibrillation or high symptom burden, we could consider the addition of digoxin. Or if they are intolerant to ACE inhibitors, we can consider older therapies like hydralazine and nitrates, for example. And then we want to assess for ongoing risk and residual symptoms to make a determination about whether patients need device therapy or referral to specialized clinics for advanced therapies. So again, exploding that top line, there's a new recommendation now that in the absence of contraindications, patients with HFrEF, heart failure with reduced ejection fraction, should be treated with combination therapy, including one medication from each of the 4 classes here, and that's a strong recommendation. The order in which you prescribe is really determined by your clinical judgment and the clinical scenario. On the second line, again, the key points here are that clinical factors should determine what additional therapy should be considered, and these drugs may apply best to subgroups of patients, not all patients, and this is where specialist input might be helpful. And then finally, after titration of all eligible therapies, think about whether they need to be referred to a specialist for device consideration or advanced heart failure therapies. And I'll just make a quick point that it matters because as we add on more and more therapies, there are examples from clinical trials using ivabradine and sacubitril valsartan respectively. That's the left graphic and the right graphic. And the story is the same. That compared to placebo or compared to usual care, when you start these therapies, we can often expect the ejection fraction to improve substantially. In the case of the PROVE-HF study that looked at sacubitril valsartan, there was an improvement, a mean improvement in ejection fraction of up to 9%, which for many patients would mean they would avoid additional advanced therapies or invasive therapies like pacemakers and defibrillators. So I'll just finish with 2 slides on how to make this all practical. We want to focus on foundational therapies in any order based on anticipated tolerance. So if you think your patient will tolerate the ACE inhibitor or the ARNI, that's a reasonable place to start. But it's also reasonable to start with a beta blocker, an MRA, or an SGLT2 inhibitor. And it's a good idea to start at the lowest or starting dose, titrate up every few weeks as tolerated, and you can change 1 or 2 drugs at a time, rechecking blood pressure, heart rate, electrolytes, or creatinine after each titration, for example, in the case of ACE inhibitors and ARNIs or mineralocorticoid antagonists. If you run into issues with intolerance or limiting side effects, it's a good idea to refer to specialists and then follow sick day practices as needed. And I'll just walk you through some of the guideline-based suggestions about initiating medications and what to watch for. If you look at the ACE inhibitor group or ARNI group, their recommended starting doses of these medications. The usual contraindications relate to very high creatinine or hyperkalemia. In the case of sacubitril valsartan, hypotension or relative hypotension is a contraindication. We don't really monitor for heart rate effects, but we do have to monitor for blood pressure effects, and when to reduce or hold the dose depends on how the kidney responds and whether there are issues with hyperkalemia. With beta blockers, they'd be relatively contraindicated in patients with severe reactive airways disease or second or third degree heart block, of course, no effect on electrolytes and renal function. We can run into issues with bradycardia occasionally, and certainly reduce or hold the dose when someone's in active decompensated heart failure with pulmonary edema. With mineralocorticoid antagonists, similar to ACE inhibitors, be on the lookout for poor kidney function and hyperkalemia as contraindications. We have to recheck electrolytes in a couple of weeks once we start the medication, and this usually has a minimal effect on hemodynamics. And of course, if hyperkalemia emerges, then we have to hold the dose. And finally, with the SGLT2 inhibitors, people who have a history of diabetic ketoacidosis at any stage, patients with very depressed estimated GFR would be relative contraindications. Can recheck electrolytes and renal function if there's a concern about volume status. They usually have a minimal effect in a heart failure patient on heart rate and blood pressure, and certainly hold or discontinue, interrupt the drug if there's a dehydrating illness that can exacerbate the risk of ketoacidosis. So in summary, new clinical trial evidence has driven the need for a guidelines update and a new standard of care. 4 drugs should be considered standard therapies for most patients. Personalization of care allows for incorporation of new or additional therapies based on clinical factors, and that includes other therapies like avabradine, vericiguat, vasodilators, and digoxin. And optimization is a challenge that should be tackled by both generalists and specialists in partnership. So I'll end there and look forward to the discussion that follows.